Well, thank you. Well, good morning, everyone. We want to thank you all for joining us this morning. Continues to be a crazy time for the planet. Here in Kirksville, we now have more cases of COVID this month than we've had since the start of the pandemic. It is just really out of control, for lack of a better way. So we really appreciate your time. It's great to continue to build a community within DO-Touch.NET. And we're doing this year, creating this online program because we don't expect that we're going to be able to have a live annual meeting this year in March. And so this is a way for us to get together on a monthly basis to continue to learn and to share some experiences. So we started last month with an open forum where we had updates from the coordinating center and from the satellite centers. And that will be something that we'll be doing every 3 months. If we go to the next slide, Jane. And so this month, we begin with our educational webinar. And we'll be looking at patient-reported outcomes for today's presentation. In December, for our third type of programming, this will be a research journal club, where we're going to be identifying the latest research in manual medicine, distributing that ahead of time so people can read it. We will have a facilitator to present the journal and follow up with discussion, not only about that specific study, but how that relates to our current practice and our future research within DO-Touch.NET. After each of these programs, we will be having a discussion forum that you can get to through the DO-Touch.NET website, and Jane will be talking more about that at the end of the program.
Yes, so our discussion forums, I will update you about that. We will be sending out an announcement about how to access that discussion forum, and we hope to continue the conversation after this webinar is done. So some of you have registered for CME credit. We are offering one AOA Category 1A credit. There are 3 things that you have to do in order to get that credit. The first is that in the chat, Zoom chat, you need to enter your first and last name because that's how we can show that you were here. Second is I will send you a link I have sent you a link of the physician attestation form that you will need to complete. And then probably later this afternoon, we'll be sending an evaluation survey. And we would appreciate if everyone would complete that, but the people who want to receive continuing education credits will have to complete that. So we realized that this was a late notice on having the availability of CME. And if you would like to have CME, but you haven't registered yet, please do enter your name and in the chat box, and the confirmation you received for this Zoom presentation will have a link to send you to register for the CME. So if you would do that by 5 p.m. Central Time today, I would appreciate that. Okay. All right. So these are things that we need to tell you in order to be able to offer CME. So the CME, AT Still University is accredited by the AOA to provide osteopathic continuing medical education. And this program is designated for 1A credit.
And that will be true for our journal club as well. For our meetings, we will not be able to offer the credit for that, but for you have the potential of getting 8 credits per year by participating in this program. Further disclosure information is that all people that have been involved in the development of this program, all of them don't have any conflicts of interest. They've all have completed their disclosures and are free of any conflicts. So that is the people that have helped develop the program. Go to the next slide. And as well as the planning committee that everybody has met standards, that there's no concern about commercial support, any secondary gain that could be gotten from the course directors or anyone on the planning committee or the faculty. And so once again, all through DO-Touch.NET and the AT Still Research Institute, all people that are involved in planning of this program do not have any conflicts of interest.
If you have any questions about the program and the CME provided, please feel free to, about the lecture, please feel free to contact me. My contact information is on the screen. Also, if you have any issues with the CME that we can't resolve for you, we can put you in touch with the continuing education director, Jan Baum.
Okay, so it is certainly my honor to be able to present this morning's speaker to everyone. Jane Johnson, who is the Associate Director for DO-Touch.NET, will be leading the webinar today. She's an Assistant Research Professor within the AT Still Research Institute. Within the university, she has finished 20 years of service. And in those 20 years, at least she has had published articles, at least 5 a year. So over 100 articles she has contributed to the osteopathic profession in regards to advancing the osteopathic perspectives, whether that is through manual medicine or other components of that. So she has been quite a productive contributor to the scientific community, very much an engaged leader within the DO-Touch.NET network. And so I'm very interested and excited to have her put together this morning's presentation.
Well, thank you, Brian. I'm excited to be here. One of the things that I learned from last time was that it is much easier to record the presentation and then I can answer questions and things like that while the presentation is going on. And so if you have questions during this recorded presentation, please feel free to put them in the Q&A. You'll find that at the bottom of your screen. We will, following the presentation, we're going to open this up for everyone. We'll have a discussion. I have an exercise for you. at the end of the presentation. And so I hope that we'll all find it enlightening and educational. So without further ado, I will. Oh, and you'll find this kind of like my live speaking because it has lots of ums and uhs and things like that in it. So. Good morning, good afternoon, or good evening, depending on where you are. I'm Jane Johnson, the Associate Director for DO-Touch.NET, and I'm happy to be joining with you today to talk about patient-reported outcomes and how they're measured. So let's start with the disclosures. So I have no financial relationships to disclose. I will not be discussing medications of any kind. So the learning objectives for our Let's Talk About OMM research series are to have you be able to provide examples of recent research findings on OMM, which you could apply to your clinical practice, be able to interpret current evidence regarding OMM and recognizing research opportunities in OMM. So why are we talking about patient-reported outcomes? So in our previous series episode, we talked about our upcoming research project or patient registry, which we call OSPREY. And we discussed the setup, the organization of how data will be collected in OSPREY, and both preceding treatment and several days following treatment. And these reports that you see on this slide are all going to come from patients. And so these will be patient-reported outcomes. In addition, we talked about the future steps for OSPREY, and one of the benefits that we see for including patient-reported outcomes in our data collection is the ability that we will have to provide you a report about your patients and their patient-reported outcomes that could be helpful to you in discussing their health with them and what their health care priorities are and how they're doing. So what are patient-reported outcomes and how do we measure them? So let's talk about what patient-reported outcomes aren't. So we're very used to in healthcare what are called clinical outcomes. They are objective outcomes, or at least relatively objective. And examples are mortality, biomarkers, blood pressure, the number of infarcts, the work days missed, somatic dysfunction diagnosis, things like that. So these are measured or assessed on a patient. Core, in his 1991 discussion about osteopathic research, stated that research designs are required that assess the effect of treatment not merely on the presenting complaint, dysfunction, or disease, but the impact of treatment on the total person and the person's ability to carry on with adequate reserve the functions that are important to him or her. In that article, he went on to describe how research designs like the medical outcomes study, which was a large study being conducted at that time, included outcome measures in 5 categories, some of which were subjective in nature, but all of which were quantifiable. So these 5 categories were physical functioning, ability to carry out daily activities, socialization, mental health, health perception, and bodily pain. So those are patient-reported outcomes, or can be. Patient-reported outcome is defined as any information on the outcomes of healthcare obtained directly from patients without modification by clinicians or other healthcare professionals. Sella said, we use this term broadly to include any patient input, whether or not it is standardized or gathered with a structured questionnaire. So a patient-reported outcome is simply something that a patient tells you about their health. And it comes directly from them. So how do we measure that? So we use patient-reported outcome measure, which is defined as any standardized or structured questionnaire regarding the status of a patient's health condition, health behavior, or experience with healthcare that comes directly from the patient. In other words, a patient-reported outcome. The use of a structured, standardized tool, such as a patient-reported outcome measure, will yield quantitative data that enables comparison of patient groups or providers. So a patient-reported outcome is the patient telling someone something about their health. You know, it could be just a comment, I feel better. Or it could be assessed using a patient-reported outcome measure. So what goes into selecting patient-reported outcomes and patient-reported outcome measures for use both in research and in clinical practice? Well, let's talk about what are different types of patient-reported outcomes. There are 5 broad categories. The first is probably one of the things we think of most when we think of patient-reported outcomes, and that is health-related quality of life. The health-related quality of life is very multidimensional. It could be generic to people in general, or it can be condition specific. It can summarize well-being, but may not specifically address a particular healthcare issue. Functional status is different than patient-reported outcomes are different from performance-based functional status measures. So measuring range of motion of joints or walking time, things like that, those are performance-based functional status measures that they're clinical outcomes. Functional outcomes are functional status patient-reported outcomes are reports from patients on how they assess their ability to perform specific activities. So they can be used in addition to performance-based measures to help strengthen assessment of functional status for a patient. There may be variations in patient-reported versus assessment from performance-based, simply because of perceptions of the patient versus observations by an outside person. Symptoms and symptom burden can be assessed, are often best assessed through patient reports. But they may miss some of the general or global aspects important to patients. And we'll go through some examples of each of these. Health behaviors are another category of patient-reported outcomes, and those typically measure frequency. How often do you perform a breast self-examination? And they can be used to target specific behaviors, but they have a weakness that often they are affected by social desirability. So someone doesn't want to admit that they're not doing their self-exams, for example. And then patient experience, like patient satisfaction. It engages patients can engage patients in their own healthcare if they are able to express their experiences, and can be related to adherence to treatment regimens, things like that, and can be related to health behaviors and to outcomes. They can be very complex and often require confidentiality, because sometimes people do not want to report negative patient experiences, once again, because of social desirability, for example. So let's look at briefly about health-related quality of life patient-reported outcomes. These are often multidimensional, assessing physical, social, and emotional well-being. Maybe one of the best-known health-related quality of life measures is the SF-36. That is a generic health-related quality of life measure. There are also what are called health utility or preference measures, like the Health Utilities Index Mark 3. There are measures that can be specific to chronic illness. For example, the NeuroQoL, which is specific for neurological conditions and chronic illnesses, could be specific, targeted at a specific disease or treatment. For example, the European Organization for research and treatment of cancer has a quality of life questionnaire. All of these measure health-related quality of life as reported by patients, so patient-reported outcomes. Functional status, looking at assessing from the patient perspective their ability to perform basic and advanced activities of daily life. So assessing physical functioning, cognitive functioning, sexual functioning. Some can be assess specific types of function, for instance, the upper limb functional index. Remember that these are patient-reported outcomes, not performance-based assessments of functional status. So something like the upper limb functional index would assess how a patient perceives the functioning of their shoulders, arms, hands. These can be targeted at a specific disease population. For instance, the Pediatric Asthma Quality of Life Questionnaire includes questions about how well the children can feel they can perform certain tasks related to their asthma, or the assessment of how their asthma affects their functioning. There are functional status patient-reported outcomes targeted at specific chronic conditions. For instance, the COPD activity rating scale. Symptoms and symptom burden look at the presence and intensity of symptoms. Symptom burden is often a combination of severity and impact. So severity, a patient common patient-reported outcome is the pain intensity visual analog scale, or a pain numeric rating scale, where you ask a patient, how severe is your pain on a scale of 0 to 10? Measures like the PROMIS pain interference scale measure the impact of pain on a person's well-being. So it's more looking at how pain affects the person. And then burden, there are scales like the Functional Assessment of Chronic Illness Therapy Fatigue Scale. So for chronic illness, how big a burden is your fatigue? How severe is it combined with? What is the impact of that fatigue? Health behaviors are often assessed, for instance, by the CDC, used to monitor risk behaviors, and these types of patient-reported outcomes are often used to assess the response to health promotion interventions. For example, they could be used to assess the impact of a local mask mandate on health behaviors of people wearing masks in public. Some examples of assessments of health behaviors. There are health risk assessments, looking at things like the personal wellness profile, insight, health risk appraisal survey. There are large scale assessments of health behaviors conducted by the CDC, the Behavioral Risk Factor Surveillance System, and the National Health and Nutrition Examination Survey are both conducted by the CDC, have been for a long term, many, many years. You can look at health promotion behaviors as patient-reported outcomes, the School Health Action Planning and Evaluation System, the Morisky Medication Adherence Scale. These are ways to assess health behaviors based on patient reports. Patient experience of care is related to patients' perceptions about their needs from a healthcare system, their expectations, and what they experienced. So things like satisfaction, patient satisfaction surveys are patient-reported outcomes. You can assess their patient's motivation and activation. Are they engaging with their healthcare system? So, like the patient activation measure, and it can be reports of experiences. For example, the Consumer Assessment of Healthcare Providers and Systems, which is an initiative of the Agency for Healthcare Research and Quality, HRQ. So how are these, I've mentioned lots of examples of patient-reported outcome measures, and how are these measures developed? Well, it's not an easy process, and if you don't have to do it, don't. But the way these are developed is, in general, starts with the generating a list of relevant issues. So by doing literature searches and specialist interviews and patient interviews, and find out what are the issues related to the patient-reported outcome that you want to measure. Convert that list of issues into questions. So you have to select what type of question response you want to use. Do you want to use ordered categories, visual analog scales, Likert scales? You have to consider the wording carefully so that you're not introducing bias to the questions. You have to look at the face and content validity for the questions that you develop. Then you pretest. So you try to get a representative sample of the patients that you would like to have using this patient-reported outcome that you're developing. And you ask them to complete the questionnaire. If they skip questions, you have to find out why they're skipping the questions. You may do some cognitive interviewing with your sample to see if you can determine how they interpreted the question, and you may have there's a whole another category of translating questions into a different language if you're wanting to use this patient reported outcome measure over over multiple languages. And we won't even start there, trying to describe all the things that need to go into that, because it's not just language translation, it's also cultural translation, things like that. So once you've pre-tested and resolved any issues there, then you go to a large field test where you have a large group of heterogeneous group of patients, and you kind of repeat what you did with the pre-test, but also trying to determine, if people didn't respond, why didn't they? Are you seeing any ceiling or floor effects? In other words, everybody's at the bottom of the scale or at the top of the scale. Are there items that just don't work? So do you need to review them? Are there subgroup differences? Things like that. And once you've processed through that, and the pre-test and the field test may not be a quick things. So they may need to be repeated multiple times. After that, then you go through the psychometric testing. So this is looking at validity and reliability, sensitivity, responsiveness, may do factor analysis, may do item response theory. You talk to your friendly statistician about that. So highly recommend that if you are wanting to include patient-reported outcomes, for instance, in your clinical practice, that you use already existing and validated patient-reported outcomes measures rather than trying to develop one yourself. So how do you select patient-reported outcome measures? Well, one of the first things is you have to decide what is the source of your patient-reported outcome measure going to be. Is it going to be the patient themselves, or is it going to be a proxy? And if you can get someone to respond about themselves, that would be best. So, because people are experts on themselves. So, sort of. Okay, but that's not always possible, right? So if you want patient-reported outcomes about a baby, okay, that baby cannot complete a questionnaire. So you may have to have a parent be a proxy. Or sometimes you may want to have both self-report and proxy report to see if they complement each other. Another consideration for selecting a patient-reported outcome measure is how are you going to interview it? Is the person going to just take, how are you going to administer it? Is the person just going to take the questionnaire themselves, or are you going to have an interviewer read and record the patient's responses? Obviously, the self-report is cheaper, and you may have more openness from the patients they may be more willing to self-report on a something that's uncomfortable for them. But you also have to look at how simple it would be to follow the logic on your patient-reported outcome. You can, if you're having someone interview, you can use more complex survey designs where, if the patient answers this way, then you ask this question, but if they answer that way, you ask that question. And if they're not answering, you follow up, things like that. But there is a potential for bias in an interview. Once again, the desire to be socially acceptable, for example. Another thing to consider is, where are you going to administer this patient-reported outcomes? Are you going to do it in the clinic, for example, when the patient arrives for their clinic appointment? Which can be, you can get more complete responses potentially if you hand someone a piece of paper, or you hand them an iPad and ask them to fill it out right there in the clinic. It can increase the staff burden, and it can be, you can end up with missing data because of interruptions. The patient gets called back, and there can be some occasionally concerns about privacy if you have a crowded clinic and someone's trying to complete a patient-reported outcome that has some sensitive topics on it. If they can do it at home, that sounds great. Once again, is it accessible? If you're doing an electronic questionnaire, do they have access to being able to do that? There's the issues of potentials about security and safety, things like that. Can you do it are you doing it in a nursing home? For example, might be another a place that you might administer patient-reported outcomes. So you need to determine which of these fit your situation best. How are you going to administer this patient-reported outcome? Are you going to use the paper and pencil? In other words, you hand the patient a questionnaire and they fill it out. That's low cost, but getting that information, for instance, into the electronic health record so that you can track it over time can be costly and time consuming. If your patient-reported outcome requires some sort of scoring, then that can be an increased burden if you're doing it in paper and pencil mode. Electronic, if you can self-administer, if the patient can self-administer on a computer, on their mobile device, on their telephone, via texting, it's interactive. It's more comfortable for some people, especially sometimes reporting on sensitive topics. You you minimize any data entry errors. You can get immediate scoring and feedback. But there are groups of people that are not comfortable with technology or may not have access to a technology that would enable them to complete an electronic questionnaire. And then there's the format and scoring for the administration. So there are classical forms, patient-reported outcome forms, where you ask a series of questions and then you just add up a score. You know, if they answered this, they get 3 points. If they answered that, they get 2 points. And on the next question, and you just add up the scores, and everybody answers the same questions. There are patient-reported outcomes that are short forms, so that take into account what's called item response theory. So some questions are weighted differently than other questions when you get the weighted score, but you're still asking the same questions to everybody. And then there's something called computerized adaptive testing, which, as the name implies, would require a computer or electronic administration of the form. But it imitates more a clinical interview. So it starts out asking one question that's kind of in the middle. For example, in physical functioning, a question that's in the middle of the range of ability, functioning status. And if this person answers that they have high functioning status on that question, then they get this question. If they answer that they have low functioning status on this first question, then they get a different question. So it hones in on figuring out what their ability is by answering different questions. So that's obviously accessing computerized adaptive testing requires more technology savvy than providing a classical weighted score. So those are the things to consider when you're selecting patient-reported outcome measures. Here's a list of the references that I used for this presentation. And now we'd like to open up a discussion about what types of patient-reported outcomes could be useful in your clinical practice. So I'd like you to take a few minutes to think about your patient population. What types of health issues do you address? And what kinds of information do you feel you need outside of physical examination and lab tests that could be obtained through patient-reported outcomes? So I will we'll be back. We'll go back to our live discussion and look forward to working together to help everyone figure out what types of patient-reported outcomes would be useful for them. Thank you. So we've we've had some really good questions in our Q&A so far, and I hope that you've been able to follow along with that. I am going to give all of you access to talk. You don't have to, but I wanted to make it available to you, so we can hopefully have a good discussion about possible ways to select patient-reported outcome measures.
Yeah, you understand me?
For use in your clinic.
Yeah. Okay. Jane, do you understand me? Hear me?
Absolutely, Sergio.
Okay, fine. Can I ask you something?
Certainly.
Okay. So I was wondering, I see interesting, not every week, but mostly interesting cases in my office, and with musculoskeletal issues. And I would like to know, sometimes I would like to take their case and do a publication about it. But according to the Ethics Committee of Luxembourg, CNR, I'm not only allowed to take this information if I have asked the patient before, if the patient has signed before a paper with approval that he or she agrees that I take this clinical information for a publication.
Right.
Sorry, Jane. What I'm wondering. Why do I need ethics committee information, as I would only sit a clinical case without name, only telling the age and the issue that the patient had before to come to my office? Is there a specific questionnaire that I could employ to not that which will not require me to have an informed consent from the patient?
I don't believe that I believe you would still have to have informed consent.
Yes. Okay.
Using a questionnaire. It's about protecting the privacy.
Yeah, of course.
Especially if it's an unusual case, that sometimes would be the person might be identifiable just by mentioning that they have a particular disease condition, for example, if it's very rare, things like that. Yeah.
Okay. So you would advise me that I go search such informed consent at the CNR office in Luxembourg, where I live, and then I ask every patient to sign this informed consent if they agree that if their case, I can use the case information without masking all the name and surname from each patient.
Yeah, you could do the case presentation. You would still need to mask their names. And,
yeah, of course. Yeah.
But yeah, if you could find an informed consent form that would allow you to
Yeah, of course.
publish their information.
Yeah, so I need to see that in my country, Luxembourg, which regularity they have as the rules, which rules they have to manage the patient information.
Mhm.
Okay.
Yes. Yeah.
And I would say that your presentation was very, very interesting.
Well, thank you. Thank you.
You know, a lot of things, I saw it during my doctorate in health science, and it was a good reminder.
Good, good. I'm glad.
Very interesting.
Thanks. I
Yeah,
see.
sorry.
Oh, I'm sorry.
No, sorry. Go on. Sorry, Jane.
Okay. So I see that Marcus has a comment. He says he can't talk right at this moment, but he says it would be interesting to hear what the patient feels, what helped with their symptoms, a technique I did, something I said, or something entirely else. And
Yeah.
I think that's a very good point.
Yeah.
Yeah. So you know, and as I mentioned in my presentation, patient-reported outcomes do not have to be a specific a specific questionnaire. You know, they can be just asking your patients. You know, ask every patient. You know, is there something I did today that made you feel better, or you know, is there something I did last time you were here that you specifically believe made you feel better? So they don't have to be specific structured questionnaires. Yeah, Brian.
Yeah, I think it's important in any part of your practice is to understand what purpose the outcome will offer. And so having, and it's also important to set up a systematic way of collecting whatever you're doing. And so if you have a particular question, like Marcus mentions about, you know, what do you feel today was particularly helpful about your office visit? You know, if it's something that is specifically to help improve your own patient care and your own understanding of the work you do, well, having much more kind of open-ended and self-created questionnaires for that purpose can be just fine. But if you're looking for something that's going to have a more far-reaching effect within a publishable environment to influence, you know, a profession or so forth, then there's certainly a greater need for standardization, for developing validity of the tools that exist. And so Jane's comment about, you know, if you're really interested in impacting from a publishing perspective, making sure that you just use those types of tools, identify which tools are going to best answer the question you want. But at that, you're not limited to that if you're really just wanting feedback for quality improvement within your own skills or your own clinic environment.
Excellent. I see from Jed Downs, his comment in the chat is, my perspective is that patient function is a lot more measurable than symptom levels are. We don't necessarily treat where the patient states their pain is, and pain is such a rabbit hole. Work has been done to produce better questionnaires. I followed the PROMIS questionnaires developed by NIH, but there has been a slow adaptation from older questionnaires such as SF36 or Oswestry. And that is absolutely the case that that there are always bigger, better, more accurate questionnaires, and going through and figuring out, do you want a disease-specific questionnaire or condition-specific questionnaire like the Oswestry, which is targeted at back pain, or something more general like the PROMIS questionnaires or the SF-36, something like that is a consideration that I hear discussed a lot when I go to meetings about patient-reported outcomes. Any other thoughts on that?
No.
Yeah, I want to make a little bit more of a statement along those lines. You know, so much is done with you know, the Likert pain scale and so forth, and to me it just comes out to be so meaningless, because so much of the level of pain is really more the measure of suffering, and it doesn't separate out nociception from suffering. And so I just think that any study which really looks at just self-reported pain outcomes is to me of questionable value. So that's just my perspective, and I really hope that things could work towards focusing on function.
One of the challenges from my perspective of assessing patient function is that each patient has inherently different levels of physical functioning. And so being able to find a range within a questionnaire that's appropriate and is going to be sensitive for that elite athlete versus the person that has different levels of disability, that's the tricky part. Certainly, I think patient function has the ability of being more quantifiable than just trying to figure out this more nebulous symptom level. So I certainly agree with that, Jed.
Well, the high-level functioning athlete is a very select group. I mean, yes, they get a lot of attention, but they're going to certainly need a different class of questionnaire than the you know, general population, or a population that has a specific disease entity.
So certainly one of the things we've been trying to do in preparation for Osprey is how do we help the patient identify which patient-reported outcome measure is most relevant to their situation, and giving them that flexibility versus us trying to predict, you know, which measures are going to be right for everyone. And I just don't think we have the ability to do that. I don't think science has been very successful at that. And so we've been working hard in developing a system that allows the patient to identify what areas are most meaningful and relevant to their concerns, and then are able to track those.
Well, if things are being done on an individualized basis, then you're not going to have the generalizability that you're looking for in terms of being able to influence the profession, correct?
Well, I would say, and I'm waiting for the statistician to give some insight there. So the issue are the trends that occur across the questionnaires. It may not be all the same, you know, condition, may be, you know, different issues between sleep versus depression versus pain versus, you know, ability to maintain daily functioning for, their daily just their daily routine. So I think there is a way statistically to be able to look at that bigger picture across different types of questionnaires. But I'm going to once again let the statistician give insights there.
Yeah, so I wasn't paying real close attention. I apologize. I was trying to answer questions online, and so I'm embarrassed to say.
So my assessment of the question was, Jed, when I had talked about our patients having the ability to determine which questionnaires that they might want to answer that are meaningful, wouldn't that then diminish, the outcomes of our work, because we can't, combine that type of data to come to conclusions. So
Sorry. Yes. So one of the things that we're going to develop statistically is in statistics, it's called a latent variable. It's a combination of information into one concept. So we have this concept of response to OMT. And, for some people, their response to OMT would be measured by physical functioning and depression, changes in physical functioning and depression. For others, it might be pain interference and their ability to participate in social functions. So what is important to them goes into this statistically developed measure of response to treatment. It also enables, so the response to treatment then being defined as, did what is important to them change? And if we use scales like from the PROMIS questionnaires that that are measured on the same scale, then it makes it easier to be able to combine those validly. Does that help?
So I know I don't remember all the different PROMIS questionnaires that were developed, but there's one, for instance, for upper extremity use, or there's one for generalized health. There are others for specific disease entities like rheumatologic conditions or whatever. And so at your initial encounter, you're basically going to say, okay, which one of these of the library of PROMIS questionnaires is most appropriate, and then you can use that one to follow the patient? Or are we talking about developing something de novo from the ground up with all the caveats that you put in regarding hardships of developing a new tool?
Right. Yeah, no, we're not doing that. So at the beginning, before their office visit, they have the option. We're not including all of the PROMIS questionnaires, but we have selected half a dozen of them that maybe a few more. Things like pain interference, fatigue, physical functioning, sleep disturbance, and they are able to, the patient, when they're filling out the questionnaire, is able to say, we ask them, which of these are your top 3 priorities for improving from this office visit? Up to the top, up to 3. Pick your priorities. And then they complete those questionnaires before the treatment and a week after the treatment.
And so if I understand correctly, there will be a few that are going to be standard for all patients, just because the majority of our patients have pain and so forth. And so there's probably 3 that will be standard, so we can compare across the whole population. But then there will be others that the patient can select that represents their condition and their concerns, which will help to facilitate certainly some subgroup analyses, as well as what Shane's saying, that there's ways that we still can statistically analyze the big picture there. I think that the biggest challenge from my perspective is for us to generate actually meaningful data is really we have to sustain data collection for over long periods of time, so that we have enough numbers, we have enough related groups and so forth to look at. And so one of the things that certainly crossed my mind is so what's going to be necessary for me to mold my practice to sustain a patient population that's willing to give that level of information, and for them to understand the importance of giving that information so that they take that time to do that. So that's something I think all of us need to think about, because there's certainly no one solution is going to apply to everybody. Everybody has a unique practice, a unique style. And so how do we build that bridge to our patients in order to sustain accurate and meaningful information? That's really going to be our immediate future challenge here.
And I hate to end this discussion, but we are at the end of its time. But I hope that everyone will continue the discussion on our discussion forum on the website. You will be receiving information about that discussion forum by email within the next couple days. So we invite you to join us on December 18th for our research journal club, our first research journal club. Brian Degenhart will be our leader for that, and we'll be getting the information about that journal article out to you shortly, and so that everyone can read it, and we can engage in a good discussion about that journal article and how it can be applied in your clinical practice.
And so once the new year begins, we are going to be opening up the presenter role to anyone within the network. And so particularly when it comes to leading a journal club, that's something that's any of us certainly can very easily do. It's a matter of identifying a recent article that would appear interesting to you as well as to the membership. So certainly as you come across them, and if you're willing to do that, email Jane the article, and we will begin kind of assigning future sessions along that line. So once again, we're just getting it started here in 2020, but come 2021, we really would like to engage all of you to lead on these programs. So thank you very much. And on behalf of DO-Touch.NET and certainly the Institute and the university at large, we want to wish everybody a very restful coming week and really have some, I think we'll all have a little extra time and unfortunately a little extra isolation to reflect on things that we can be thankful about, even in the midst of these challenging times, to identify what's really important in our life and to be thankful for them, that they're part of our life, I think is really important. So we want to wish you continued safety, health, and we look forward to seeing you then on 18th of December.
Thanks so much, Brian.
Thank you all.
And Jane. Thank you, Jane.
Thanks.
Thank you.
Back at you
Thank
guys.
Jane. Thank you, Jane.
Thanks.
Thanks.
Bye-bye, Jane. Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye.